Okay, so we're going to be talking about some of the risk factors affecting oral health. And I'm Caleigh, and I will be going over HIV and AIDS and neutropenia.
And I'm Rain, and I will be discussing Down syndrome and leukemia today.
Okay, so starting off with HIV and AIDS, this is a disease that attacks the immune system. It starts off as HIV, and then as this disease progresses, it becomes AIDS, which is even more severe. These infected individuals are more likely to develop infections and certain cancers due to their compromised immune system. Specifically, it's going to cause decreased monocyte chemotaxis, decreased phagocytosis, so the ability of the body to send the neutrophils and other immune system components to the site of infection is reduced, and it also reduces the ability to engulf bacteria and to kill the antigens when they're in the body, and it also reduces CD4 T cells, which are important for recognizing antigens and creating antibodies as well. Some oral manifestations include hairy leukoplakia, candidiasis, herpes labialis, aphthous ulcers, Kaposi sarcoma, linear gingival erythema, which is also called HIV-associated gingivitis. This is a picture I found that shows some of these oral manifestations. So you can see at the top, you have the necrotizing ulcerative gingivitis and periodontitis. You have the gingival erythema, which is that redness along the gingival margin. And you're also going to see this in patients even when there really isn't that much plaque to be causing gingivitis. And then non-Hodgkin's lymphoma, erythematous spots throughout the mouth, pseudomembranes, hairy leukoplakia along the tongue, and then Kaposi sarcoma. HIV and AIDS and periodontal disease. So these individuals are more prone to getting periodontal disease in general and just having that gingival recession and bone loss. But also when they have it, it's going to progress more quickly. So they're going to have increased attachment loss and gingival recession. And then also they're more likely to get necrotizing periodontal disease and also delayed healing if they do form those ulcers or if they have any dental treatment done or a periodontal treatment, it can take longer for them to heal afterwards as well. So some preventative steps that these patients can take just to maintain their oral health and their comfort. They can visit the dentist regularly, practice good oral hygiene at home, so brushing and flossing daily. And then if they do have oral sores, they can be managed with corticosteroid mouth rinses or salt water rinses can be helpful as well, just to reduce some inflammation and pain with those. And then they can take they should take their HIV medication as scheduled. These are going to be antiretroviral medication. And then those are just two examples. And then if that medication is causing dry mouth, they should let their doctor know because that can increase their risk for caries and bacteria to build up in their mouth, which can be bad for periodontal disease and just their overall oral health. And then if they do not have a regular dentist they see, they can ask their doctor for a referral to one. Some treatment for HIV and AIDS patient. They are able to undergo periodontal therapy if they have undetectable viral level and a high CD4 T cell count. So this really is gonna want it to be above 500 cells per millimeter cubed of blood. And all this information can be obtained by collaborating with the primary care doctor and other healthcare professionals that see this patient as well. And then you're going to want to use a 0.12% chlorhexidine gluconate mouth rinse. And the doctor may also want the patient to pre-medicate with an antibiotic. You're going to strictly follow infection control guidelines to keep yourself safe because this is transmitted via needles and blood and stuff like that. And then you also want to do that to keep the patient safe as well because they are immunocompromised. They're going to possibly need more frequent maintenance visits as well. And the next disease is neutropenia. This is a condition that causes decreased levels of polymorphonuclear neutrophils, also known as PMNs. These are really important for fighting infection. So a person that is diagnosed with this, it's diagnosed when their neutrophil level falls below 1,500 cells per microliter of blood. This could be caused by genetic factors, which is also called cyclic neutropenia, or it could be caused by a bone marrow transplant failure, because this is where neutrophils originate from. It can be drug-induced, and it can also be radiation-induced if that patient is undergoing any type of therapy for cancer already. This is going to increase their susceptibility to infections caused by bacteria. Neutropenia and periodontal disease. So again, these patients are more susceptible to periodontal disease due to their decreased ability to fight off bacteria. It's associated with higher plaque scores, more inflammation and bleeding of the gingiva, more severe bone loss, and also ulcers. And you can just see in that picture how red that gingiva looks. This neutropenia can also cause oral sores. So I just found a picture that shows on the left side, you can see those sores, and then the right side is after they have healed. I believe it said 10 days, and there's really not much the patient can do with this besides maybe doing the warm saltwater rinses or certain mouthwashes with antibacterial components. Treatment for patients with neutropenia. So you're going to want to follow infection control very strictly because, again, these patients are immunocompromised, so you don't want them to contract any type of disease. You can also use the 0.12% chlorhexidine gluconate mouthwash. This could be helpful to decrease plaque and inflammation before you start treatment. It kind of reduces the bacteria that's just going to be flying around. And then also follow that with your gentle instrumentation. The dentist may want to use a pre-med for these patients as well. And then home care is very important along with regular hygiene appointments. So some home care includes brushing twice daily, using antibacterial mouth rinses that do not contain alcohol, just because those can be more irritating to the mucosa, and it can dry their mouth out even more. And then they're going to want to rinse their toothbrush thoroughly between uses to reduce the bacteria that grows on that. And some patients even will have 2 toothbrushes so that one can fully dry out before they use it again.
Moving on to Down syndrome and its characteristics. Down syndrome is a genetic disorder caused by gene problems that occur before birth. This is a lifelong condition that may cause intellectual disability, developmental delays, and health conditions. Characteristics of Down syndrome include a smaller than normal maxilla, bridge of the nose, and the bones of the midface region. So these are all going to be smaller than normal. A high vaulted and narrow palate. Lips may grow large and thick. Decreased muscle tone, therefore the mouth may droop and drooling increases. The tongue may also develop cracks and fissures with age and can contribute to halitosis, which is bad breath. Problems associated with this include mouth breathing, a protruding tongue, a strong gag reflex, and anxiety associated with oral stimulation. Down syndrome in the dental setting. Down syndrome is one of the most common birth defects. Therefore, we are going to be most likely seeing these individuals in practice. Patients with Down syndrome are more susceptible to congenital heart defects, infections, respiratory problems, GI abnormalities, and childhood leukemia. It is important that we know these things because it can help us in developing our treatment plan, as well as keeping our eye open to possible oral manifestations we can see with some diseases. Down syndrome and periodontal disease. To the right, we have a photo of an individual with Down syndrome that has periodontal disease. Individuals with this condition may experience severe and rapid periodontal disease. Etiology of periodontal disease in persons with Down syndrome may have more to do with the altered immune response rather than poor oral hygiene. So rather than them brushing every day, flossing every day, doing what they need to do, their immune system isn't doing what it's supposed to do. Impaired PMN chemotaxis or taxis and phagocytosis may explain the correlation of Down syndrome and periodontitis. Treatment for patients with Down syndrome. The severity of Down syndrome in individuals vary, so it is important to know how independent the patient is when giving oral health care education, as well as demonstrating proper brushing and flossing techniques. So some individuals with Down syndrome may be very independent and can do all these things by themselves. And some people may be dependent on a caregiver, so it may be important to educate the caregiver more than the individual with Down syndrome. Early and frequent visits can help prevent periodontal disease and get the patient used to visiting a dental office. So allowing them to get in young is going to help them have less anxiety and maybe a better oral health care routine in the future when coming to the dental office. Maintain the importance of an established oral health care routine. So again, always educating our patients on a good oral health care routine. Leukemia. Leukemia is a cancer of the blood cells that begin in the bone marrow. It is the most common cancer in children younger than 15. It is most common in boys and men. Treatment for leukemia involves chemotherapy majority of the time, but may also include radiation therapy, bone marrow transplantation, or biological therapy. It's important that we connect with the physician and just know what is going on throughout the individual's treatment. Leukemia and clinical signs. To the right, we have a picture of an individual with acute myeloid leukemia. In picture A, we see here that the individual has caries on the molars. In picture B, we see the cracked lips and the gingival enlargement back here. In picture C, there's buccal bleeding right there. Leukemia can cause gingival inflammation, red, purple, glossy gingiva, spontaneous bleeding, gingival enlargement, and are more prone to oral infections due to the impaired immune response. Oral mucositis, sloughing of mucosal surfaces, and ulcerations are all common complications of chemotherapy. Regular dental visits should be made to manage these conditions because it can cause pain to the patient. Xerostomia is another complication of chemotherapy. This can affect talking, swallowing, taste, and can cause rapid progression of caries as well as rapid growth of C. albicans and the development of oral candidiasis. Treatment for patients with leukemia. To the right, we have a photo of an individual with oral mucositis from chemotherapy. So we may see this in practice in the future. Dental professionals should be very familiar with the oral signs of leukemia, as it can be one of the first signs that someone has it. So knowing that the signs that I talked about earlier of leukemia that we may see in the oral cavity are very important to know. By doing our IOEO exam, We can note these clinical signs and make a referral for further examination. Anti-cancer therapies for leukemia can severely affect the oral cavity. Therefore, optimal oral care is needed to prevent these oral diseases. And chemotherapy can cause a sore mouth, so recommending products that help your patient can be beneficial. So using a soft bristle toothbrush instead of a hard bristle toothbrush can decrease the bleeding, and also the patient's probably going to be in pain from the oral mucositis. So having that soft bristle toothbrush will reduce the pain. Also, I'm sure that using non-alcoholic rinses will be helpful too, just so it doesn't burn that sore in the mouth. Q&A time.
Question 1. What is the optimal CD4 T cell count that a patient with HIV should have in order to undergo dental treatment? Any guesses?
Greater than 500?
Yes, it's going to be greater than 500 of these cells per millimeter cubed of blood. And question 2, all of the following are oral manifestations associated with neutropenia except you have A, ulcers, B, Kaposi sarcoma, C, higher plaque scores, or D, inflammation and bleeding of the gingiva. So that one is going to be B, Kaposi sarcoma, because that is actually associated with patients that have HIV.
Question 3, true or false? Etiology of periodontal disease in individuals with Down syndrome has to do more with the altered immune response. Do you know the answer?
True.
Yep. And then question 4, how might the gingiva appear on a patient with leukemia? The answer is it's going to be red, purple, and glossy. And we have the answers here, so you can go back through and study what you need to study. And that is all we have. Alrighty.